Assalamu alaikum. Today's paper is a case report titled Contribution of Endodontic Pathology to Persistent Orofacial Pain. It was published in the JOE in 2022 by De Armas et al. This case report describes the successful management of a complex case of chronic orofacial pain in a patient with non-odontogenic chronic pain condition in a maxillary tooth with persistent pathology after endodontic treatment. A 55 years old female patient presented to the clinic with a chief complaint of a pain in the upper left quadrant that began after non-surgical root canal treatment was done to tooth number 15 3 years ago. The patient categorized her pain as constant and dull with an average intensity of 7 out of 10. Upon palpating near the apical area of tooth number 15, she felt sharp shooting pain, which she described as 10 out of 10, which radiates to her left eye and forehead. The patient mentioned that she did not remember experiencing any pain from this tooth until after the treatment was completed. 2 years after the primary treatment was done, she was referred to an endodontist for non-surgical retreatment of tooth number 15 because of the symptoms. The surgical retreatment was completed and the patient continued to experience pain, including sensitivity to cold, leading to the endodontic assessment of the need to do non-surgical root canal treatment to tooth number 16, which was diagnosed with symptomatic irreversible pulpitis with symptomatic apical periodontitis. Even though they did root canal treatment for tooth number 16, her condition did not improve and she still experienced pain. The patient presented again to the clinic. An intraoral examination revealed tenderness to palpation to the left masseter muscle, which produced severe pain. Also, tooth number 15 and 16, both of them, had severe percussion response and also to palpation. CBCT scan was taken and revealed a lateral radiolucency on tooth number 15. Tooth number 15 was diagnosed with a previously treated with symptomatic apical periodontitis, and the etiology of failure was attributed to a persistent intraradicular biofilm. For a better assessment, a selective anesthesia technique was performed by giving the patient a buccal infiltration, and after 10 minutes, the patient reported minimal pain reduction from 7 out of 10 into 6 out of 10 only, suggested that the patient ongoing pain was primarily maintained by the CNS. Before initiating the retreatment, she was referred to her neurologist, and her neurologist recommended using gabapentin 600 mg 3 times a day, which is a medication used to treat neuropathic pain and seizures. She was referred to an orofacial pain specialist, which he noticed that she had tender to palpation to the masseter muscle, which reproduced some of her pain symptoms, and also she has clenching of teeth increase the patient pain level. So he prescribed a muscle relaxant and topical benzocaine. After that, the patient was referred to the endodontist to perform the endodontic retreatment, which was completed, and the second treatment visit. The patient reported that her pain levels had decreased moderately to 5 out of 10 from 7 out of 10. When the patient returned for the 6 months follow-up, she reported also another reduction of the frequency of pain to be 4 out of 10. While there is a 10 out of 10 sharp shooting pain on palpation in the level of the vestibule. Also, she mentioned the decreased overall pain was due to the increasing dosage of the gabapentin to 900 milligrams by her neurologist. Tooth number 15 was restored with a pose and core. A new CBCT was requested, which showed the same area of low density like the previous CBCT, suggesting that the non-surgical retreatment did not resolve the previous problem. Tooth number 15 was diagnosed with a previously treated with symptomatic apical periodontitis, and surgery was done to the patient. 3 months after the surgery, the patient reported a decrease in the pain intensity to 2 out of 10, and she was able to function with her tooth, and also pain at the apical area of tooth number 15 was reduced. However, she occasionally experienced some sharp spontaneous pain in the area. 6 months recall was cancelled due to the COVID pandemic. The patient returned after 1 year and 6 months, and the patient reported that the tooth is now normal and she can function on it, but sometimes she feels mild pain episodes on the upper left side, and also she mentioned that she keeps seeing her neurologist on a regular basis, and this pain is being controlled by using gabapentin 600 milligrams 3 times a day. At the end, management of these cases show how complicated it is to deal with these type of cases with a complex orofacial pain. Clinical and radiographic examination is very essential, and in order to make an accurate diagnosis and the treatment plan, the endodontist first need to carefully listen to the patient chief complaint and also to gain their trust.